Hello and welcome to today's webinar, The Benefits of Shockwave Therapy in Muscular Injury Recovery. This webinar is presented by Zimmer MedizinSystems. I'm Regina West and I'll be moderating the webinar today. At any point during the presentation and Q&A, you may submit questions by typing them in the Questions tab on your webinar control panel. Following the presentation, we will cover those questions live, and if there's not enough time remaining to address all of the questions, answers to your questions will be emailed to you. Gerald Gable, a webinar panelist, will briefly contribute some additional information following today's presentation. Now I'd like to introduce the speaker for today's webinar. We have Dr. Davis McAlister standing by. Let's bring him on camera now. Dr. McAlister, would you please join us?
Good evening.
Hi, Dr. McAlister. How are you tonight?
I'm doing great.
Well, thank you so much for joining us today, and we'll get to your presentation in just a moment. But first, I'd like to share a little bit of your background here on this slide and talk about your bio for just a few minutes. Okay, Dr. Davis McAlister is an author, public speaker, veteran, coach, and doctor of chiropractic. He specializes in sports chiropractic and is a certified strength and conditioning coach. Dr. McAlister is a clinic faculty doctor at the Parker University Chiropractic Clinic in Dallas. He provides valuable instruction to doctors, trainers, and strength and conditioning coaches. He also works with high-performance athletes and coaches powerlifting. With over 20 years of diverse experience, he has taught and coached in Texas at the high school and university levels. He also served in the U.S. Army for 8 years before earning a Bachelor of Science from Mississippi State University, and he was awarded a Master of Educational Leadership from Sewell Ross State University and a Bachelor of Anatomy, a Doctor of Chiropractic, and a Master of Strength and Performance from Parker University. So if you're just joining us, I have just introduced Dr. Davis McAlister, who will be speaking on the benefits of shockwave therapy in muscular injury recovery. Welcome again, everyone, and again to you, Dr. McAlister. Thanks again for joining us, and if you're ready, I'll hand control of the presentation over to you, and we should be able to see your screen in a moment.
Okay, sounds great.
It's all you. Take it away.
All right, sounds great. So I'm really excited about this. This therapy has been absolutely beneficial for my patients and muscular injury recovery and working with athletes and all those things. So I'm really excited to be able to share the information on this with you, and then hopefully you can be able to turn around and be able to start using this and helping your patients as well. So our overall objectives today are to understand what extracorporeal shockwave therapy is and understand how it will benefit your patients for musculoskeletal recovery. So the main device that we've used is the Zimmer enPulsPro. There is one other type of model that is just as beneficial and works just as well, but this is the one that we actually happen to have. So let's start off by understanding what shockwaves are. Shockwaves is a high energy acoustic wave that's generated outside the body. So in this case, it's going to be generated by a device through an applicator and transmitted through the skin and underlying tissues to a target area that we're focusing on for that particular patient and whatever their injury is. So it's non-invasive medical treatment. Again, using high energy shock waves, it's going to help stimulate healing in various parts of the body. So it's going to use focused shock waves, and we're going to talk about a couple of different types of shock waves that are generated from a point source, again, what we're referring to as an applicator, and focused into a specific area. They are high energy and can penetrate deep into the tissues, making it effective for treating deeper injuries such as tendinopathies, which is one of the main things that we're going to be discussing today. So I want to make sure we understand the difference between a focused extracorporeal shock wave versus a radial. Focused has a focal point where the highest energy shock waves are deep within the tissue, and it actually is meant for a destructive effect. And we'll get into a little bit of the history of this, but one of the main uses for it was lithotripsy, being able to break up kidney stones. So that's kind of the what that focused ESWT is, versus radial. It's a higher energy and can penetrate deep into the tissues, but the highest energy is generated on impact and then diffuses out through the tissue, making it effective for treating deeper injuries like tendinopathies. And this is really attributed to the evolution of applicator design over the years, and being able to take it from a negative effect to more of a therapeutic effect that's going to be conducive for musculoskeletal conditions. So when we look at this, you can see the diagram here. On the left, you have the focused shock wave. So if you notice, the shock wave source is a little bit broader, has a little bit longer platform to it. And then as the waves are generated, they're generated down into a single focal point, which, as we referred to, is more of a destructive type point because of the focal point that it has. Versus the radial tends to have a little bit smaller source and platform for those the transmission of those shock waves, and then it diffuses and breaks out and diffuses out through the tissue. That way it passes through the area of pathological tissue. A little bit of history on ESWT. It was first started being used early in the 1980s, where they really started doing a lot more research. There is some information that dates back to the 1960s and things like that, but where it really started becoming a focal point for therapy and research was in the 1980s. It originated in Europe, mainly in Germany, and they noticed that patients had pain relief and improved range of motion in a treated area, even though what they were trying to treat is kidney stones. And that led to some research in musculoskeletal disorders. Then as it progressed into the mid-90s, they had the first published studies for ESWT for musculoskeletal conditions, in particular, plantar fasciitis, tennis elbow, and calcific tendonitis. Then as the evolution continued on, you have the FDA approval for chronic plantar fasciitis that happened in the year 2000. 2002, it expanded out to tennis elbow, or what we know as lateral epicondylitis. And then 2004, what was interesting is we got FDA approval for non-union fractures, being able to stimulate those bone endings to heal and a little bit faster. And then in 2008, you have approval for calcific tendonitis. And if you notice the machine, that is one of the early machines there. You can see it's quite large, has you can see the applicator that's there on the patient's ankle, and it's quite large and broad. So let's talk about some of the drawbacks from those earlier designs. They did have to have nerve blocks. The treatment was quite painful, and it was extensive, and it took a long period of time. So treatment times were on average about 30 minutes. So they had to put a nerve block in order to be able to, for these patients to be able to endure the treatment. There was significant downtime afterwards. The patient had to have some recovery time, and you saw how large the machine was. So there was a special room that was required just for that particular machine, which then lends itself to, if you look at it from a practice management standpoint, you have the extended treatment times, you have a single room that has to be dedicated to that. So that's going to develop into scheduling problems from a practice management. So some of the things that you can experience, sorry, I have some things blocking my screen. Give me one second. It can be temporarily painful during the treatment. It can cause some skin irritation and bruising. It may not be as effective for some musculoskeletal conditions that we can talk about. And I have it on here as a drawback, but it may not necessarily be a drawback because it is not typically covered by insurance. But that lends itself to, if you don't collect insurance, then it's not necessarily a problem if you're already providing cash-based services anyway. And we'll get into some of that a little bit later on. Now, some of the advantages of this is it's non-invasive. There's no anesthesia that's required. You don't have to do a nerve block or anything like that. The treatment times are a lot shorter. care itself is more affordable than it was when it originally started. There's minimal downtime, if any at all, and it just kind of depends on the diagnosis and what you're dealing with. And then there's potential long-term effects, with very few side effects associated with it. So if we look at the video there, you can kind of see where, see how that the device creates that impact that's right there on the surface. So there's a projectile within an electromagnetic coil that's rapidly accelerated, and it's accelerated over and over again. That generates that pulse, and that video there is kind of in slow motion, but you can see how it penetrates out and diffuses out through the tissues that we talked about. So this is going to generate some kinetic energy that's transferred out into the tissue in the form of that shock wave. So when we look at the differences, the earlier designs were compressed air devices. And so if you notice there, the peak energy was very, very quick, very short amount of time, and that contributed to the increased pain that patients experience during treatment. So with the enPulse, if you notice that the peak time is a lot slower, it has a longer rise time, and it decreases that amount of effect that you have that's going to increase the pain, and that peak energy is what causes that discomfort. So that's the thing that we're trying to minimize. Also with this type of system with the electromagnetic coil, with the applicator, there's less maintenance that's involved, and it's a lot more endurable because when you're using these, it's repetitive. And you're going to have to use these multiple sessions with patients. And if you have multiple patients, so they have to have something that's going to have a lot more durability to it, which this one does. Let's talk about some of the therapeutic effects. Now, initially, it is intended to create some micro trauma, which will initially create an inflammatory response for the patient, but it's also going to help with relief, with the release of endorphins, where you're going to get the pain reduction after you get going with it. It's going to help increase blood flow to the area, and again, the anti-inflammatory effects overall, because as you get more blood flow into the area, you're going to get a lot of the fluid flushed away, and it's going to help decrease a lot of that swelling that you get associated with an injury. It's going to help with tissue regeneration, and it's going to help with some of the scar tissue, some of that remodeling that needs to take place. It's going to help with that process. You're going to get muscle relaxation. The patient's going to be a lot more relaxed after the treatment, and then they're going to increase their mobility, function, range of motion, all those things that we really want for our patients. Now, the biological effects, this is the stuff that I thought was really, really interesting. So it's going to stimulate cell proliferation and differentiation, and it's been shown to stimulate the production of growth factors, in particular vascular endothelial growth factor, and transforming growth factor beta, which is going to promote the proliferation and differentiation. And then with that, you're going to have increased neovascularization, so you got new blood vessels that are starting to develop. It's also going to help with the damage of blood vessels and increase the reproduction of those. You're going to have disrupted calcification. It's going to break up all those that are going to be found within the tendons, ligaments, in particular the joint capsules that can develop, especially with the trauma. You're going to have reduced inflammation that we talked about, the modulation of pain due to the endorphins and the inhibition of pain receptors in the area. And then you're going to have stimulation of tissue remodeling. It's going to promote the stimulation and production of extracellular matrix components and enhance the activity of fibroblasts and osteoblasts in the area, which is why it also is effective for non-union fractures. So some of the indications, these are things that, especially where FDA is concerned, that have been approved for some of these. You have tendinopathies, such as Achilles tendonitis, patellar tendonitis, tennis elbow, plantar fasciitis, which was one of the early treatments that it was studied for, and a common cause of heel pain, so it's been approved for that. You have calcific tendonitis, that's going to help break up those calcification and calcium deposits that form in the tendons, and that's going to cause some pain and limited range of motion, so it's going to help with that. Myofascial pain syndrome is another one where you have muscle pain and stiffness. usually because of the trigger points that'll help break up those trigger points. You're going to have non-healing fractures that we talked about. And then over in Europe, it's been studied for erectile dysfunction, and it is starting to expand over here to the US some. But there's some research that's being developed for that. And so then we want to get into some of the side effects. So everybody wants to know what the side effects are. So you have mild to moderate discomfort that can happen, or pain during the treatment, sometimes during the days following the treatment. It's not very typical. I can tell you we didn't have any of those issues, but we have to at least share full disclosure of what the possibilities are. You can have some bruising and swelling at the treatment site, depending, in particular, the smaller areas like around the wrist, ankles, things like that. You'll tend to see that a little bit more. It can cause a little bit of skin redness and irritation. Some of the rarer conditions that you may see some numbness and tingling or a headache. I'll be honest with you, up to this point, I have not seen that with any of my patients up to this date. But and then in very, very rare cases, you may have something like tissue damage, nerve injury, or blood clots. Again, just providing full disclosure, and these are things that you're going to want to have to put in your consent to treat anyway. So some of the red flags and contraindications, those are always good to know. Things like pregnancy, those you don't want to do that on the site of where a woman's pregnant. Blood clotting disorders, you don't want to dislodge a blood clot if somebody has a history of that. Open wounds and skin infections, cancers, tumors, a lot of the things that you would typically see for any type of ancillary treatment that you would provide in your office anyway. So a lot of this is not any different. Now certain things like nerve and vascular disorders, peripheral neuropathy, DVTs, Raynaud's disease, peripheral artery disease. There is some research that is going on out there, though, that these may not necessarily be true red flags or contraindications. There's some research to determine if this is truly effective for being able to help with some of those conditions as well. So be on the lookout for that. Now, I wanted to provide a case study for you. So this is one of my patients, information on one of my patients that I had. He's a 20-year-old male. D1 college player, wide receiver, had been sent to me, had injured himself on a play. One play was pretty destructive for him. He had a right torn hamstring, and I'll actually show you the picture of the discoloration that went with that. He had a left strained hamstring that was proximal up near the ischial tube, and then a right AC joint sprain. And we were mainly focusing on the hamstrings because those are the things that were being most restrictive for him. He had a pain scale on average of about an 8 out of 10, and it would jump up to a 10 out of 10 when he tried to get up and do things on his own. He had an antalgic gait, had to walk with crutches when he first came into our office. He was not able to run at all. Lifting weights was absolutely out of the question, and so he was actually having troubles with some of his ADLs, like trying to dress himself and do those things. He was having to have help from family to be able to do those things. So this is what we did. We managed to get an ultrasound on it. You can see the discoloration there, even down below the knee. That's where some of the blood had kind of drifted down and pooled. This is about 2 weeks after the initial injury. So you still see that there's a significant amount of discoloration there. And then in the scan there, you see those dark areas. Those dark areas indicate where the muscle tissue was damaged and torn. So we did have visual confirmation that there was a tear in that muscle. So when we started looking at this, I wanted to look at the research that was associated with hamstring injuries, because a lot of the stuff that we had looked at initially dealt with the plantar fasciitis, calcific tendonitis, tennis elbow, those things. I wanted to see if there was research out there specifically for hamstring injuries, and we did find some things. There was a couple different studies out there. I looked at what their procedures were, how many treatment sessions that they did per week, how many, now they call them shocks, but it's the stimulation of that applicator, how many they did in a session, what the frequency and energy levels were. These are all different settings that are on the machine, and we'll have a little bit of a chance to be able to see some of that. But if you see on average, about 3 treatment sessions per week, and they did about 2,000 shocks per session. And you notice the frequency was anywhere from 5 up to around 10 hertz, with the energy level anywhere from 0.08 up to 0.28 millijoules per millimeter squared. And the setting is a little bit different on that. It ranges up from 60 up to 100. We'll look at that here in a minute. So this is what we did. The overall summary. This is what I was able to find as far as treatment for hamstring injuries. There was a 60 to 90% success rate, depending on the severity of the injury. And then the rates were based on mainly 3 metrics that they used. They had pain reduction, functional outcomes, and then patient satisfaction with the treatment overall. So 60 to 90% is pretty good. So this is what we decided to do. We had a couple weeks because they were trying to get him back. It was in the middle of a season. We're trying to get him back quickly. He had already gone through some stuff with their physical therapist at their team facility, and they were not getting the results that they wanted. He heard about me through the grapevine and ended up calling, and then that's why he ended up coming to see me. And so we were trying to get him back to playing as quickly as possible. So this is what we decided on, what was going to be best as far as our protocol. We went 3 to 4 sessions per week. It was more 4 than 3 for 3 solid weeks. And when we did our treatment protocol, we did 2,000 pulses per session. We set the frequency at 10 hertz, and we did kind of work it up a little bit. But that was kind of our average, just staying right around that 10 hertz on the frequency. And then our energy levels, we started off at 60 for the treatments through the first week. The second week, we were at 80. And then on the third week, we had moved up to 100. And then we also incorporated some rehabilitation in there. We had some isometrics, and then we had some muscle release and those types of things for the antagonistic muscle groups so that we can try to get the stress off of the injured muscles. So at the end of the first week, pain scale dropped down to a 3 out of 10. He was able to actually become ambulatory without the antalgic gait. He was actually able to start walking normal again without the crutches. He was able to stand unassisted and was able to walk without any assistance. So that was good. That was just quality of life for him, but it was enough for him to say, this is really going to be able to help me. And when somebody's injured like that, they always have that question in their mind, man, am I ever going to get past this? Is this the end of my football career? There's all these things that they're worried about. And so the end of that first week, he was really sold that we were going to be able to help him. At the end of the second week, the VAS dropped down from a 3 out of 10 to a 1 out of 10, which was great. He was able to perform isometrics independently, and without me having to do it, he was able to actually consciously do them himself, and he was able to actually start getting out and jogging. That was a really, really good sign. At the end of the third week, his pain scale dropped all the way down to 0, no pain at all. Not on walking or anything. We were able to squat up to we worked up to about 75% of his max weight, which for him, it's a pretty good amount of weight. He's a D1 athlete. And then he was able to sprint straight line at 75 to 85% of his perceived effort. So with that, him being able to do that, that was a really good prognosis, and we were anticipating that he was going to continue to recover. We were able to send him, back to his facility, and they were able to take over from there on rehabilitating his run and getting stronger again. So the equipment, again, this is the device that we used. You can see the applicator that's there. That's the charge cord that runs back to the main device itself. You have the blue cap there. I mainly use the blue cap for areas that are smaller, such as wrist, ankles, things like that. I did have a couple of athletes last football season that we were working on some tendinopathies that had sprained ankles and things like that. So we were able to work with them on that. And you can kind of see the screen on the device there. So on the far left, that is your hertz that we would designate. And so that knob on the left would adjust the hertz. And then you would have the middle, which is our energy level. And we talked about that goes from 60 up to 100. And so the knob on the right there controls that. And then you can see the amount of pulses and all those things that are delivered throughout the course of treatment. So overall specs for the enPulsPro. So the energy levels are anywhere from 60 up to 185 millijoules, and when you adjust it, it adjusts into 10 millijoule increments. So you can see that little bar that we saw on the previous screen. It kind of moves up in 10 millijoule increments. Frequencies is anywhere from 1 up to 22, and again that adjusts, and you can see that on the screen. It has an electromagnetic drive system applicator, which is deal with the blue cap, the hand piece there. It does have a 2 million pulse warranty on the applicator. You have 3 applicator tips. You have a 6 millimeter, 15 millimeter, and a 25 millimeter. I can tell you that when we were doing his treatment with him, we were using the 25 millimeter because of the focal areas that we were dealing with. But we were also dealing with a large muscle group. So, we took that middle road as far as deciding which applicator to use. Depth of penetration is anywhere from 40 up to 50 millimeters deep into the tissue. And then it's nice because while you're using that hand device, there's a foot switch, and it's multi-directional, so it doesn't matter which way you touch it from, but it will start generating those pulses and activate, and it frees your hands up to be able to do what you need to do as far as holding the applicator and then working with the tissue itself. So that's the information that I have to share about it. I really appreciate the opportunity to be able to come and be able to share my experience with using this wonderful device and being able to tell you how it's been able to help the patients that I've had. And that football player, he's been one of the worst cases. So anything that's a lesser degree of that, you're going to have success with. And you saw the success that we had with him. So, thank you again for having me on. And Regina, we'll let you take back over.
Yeah, for sure. And we already have a couple questions coming in about that case study that you went over. So we'll see you back in just a couple of minutes for the Q&A portion. Thank you, Dr. McAlister. Chock full of information. We really appreciate your presentation.
Thank you.
Thank you. And we'll see you back in just a moment. And I will now take the screen back. And I will now like to introduce Gerald Gable, who he would like to say a few words before we begin the Q&A. Gerald is the VP of Sales at Zimmer MedizinSystems USA. Gerald, thank you for joining us. How are you this evening?
I'm excellent. Thank you, Regina.
Okay, great. Take it away, Gerald.
All right. Thank you, Dr. McAlister, for sharing your in-depth knowledge on shockwave therapy and also your excellent case. That was really impressive with the enPulsPro. I'll promise I'll make my part really short because I'm sure there are lots of questions rolling in for Dr. McAlister. So let me start with a quick video that demonstrates the strength of the radial pulse therapy and the enPulsPro. So what you can see here flying through the air is a €2 coin. And the €2 coin is the heaviest of the euro coins that we have in Europe. And it's about twice as heavy as a quarter. So it's very impressive how fast that can be shot. And, many of you might ask yourself, how is it possible that such a small handpiece or such a small device can create such an impressive acoustic wave? And the answer is, it's the laws of physics. We have the Newton's law of force, which is force equals mass times acceleration. That means if you increase the mass, you can decrease the acceleration force, the acceleration speed. And you can see in that picture below, there's the projectile that works inside the electromagnetic drive handpiece. On the right side, you see the enPulsPro projectile next to a compressor-driven projectile. And with that, you can really create that so-called soft shot because it's 5 times heavier. And you can see in the curve, the red one is the compressor-driven one and the blue one, the electromagnetic-driven one. And as Dr. McAlister mentioned before, with that spike, you have that snappy feeling on the skin, which we can avoid with the electromagnetic-driven handpiece. You can compare it with hammering a nail into the floor with a tack hammer, versus a sledgehammer. You need to accelerate the hammer much faster with a tack hammer, and with the sledgehammer, you barely need to accelerate it anymore to get the same impact force and the nail in. So again, that really efficiently enables us to transfer the energy from the handpiece to deep tissue structures, and the treatment is comfortable, more comfortable for the patient, but also for the practitioner, because there's no recoil, because it's durable build and heavy, so no recoil on your hands. We can offer the super 2 million pulse warranty. We have no need for handpiece rebuild kits, and it's very, very low in maintenance. Some other additional benefits for you in your clinic: it is cash positive after the first patient per month. It is absolutely not a hard sell for you as a doctor. It's just giving the patient alternative options, like, for example, for faster recovery in athletes, as we have heard from the case of Dr. McAlister. And only think about the weekend warriors that come to your clinic who want to get back on the tracks, on the field, or whatever sports they play as fast as possible. It's also an alternative to steroid injections or medication, and even it can be an alternative to surgery in some cases. And last but not least, it is a great marketing tool for you and your clinic, because you can position yourself as a practitioner who uses cutting-edge technology and is up to date with the technology in its field. And you'll see that, you know, patients nowadays are Googling for their indications, and they will find Shockwave, and they will look out and search and go to the doctor, to the clinic that offers these new and high-tech technology. That's it from my side already. I'm gonna hand it over back to Regina and Dr. McAlister to cover all the questions that have been coming in.
Okay, thank you so much, Gerald. Thanks a lot.
Thank you, Regina.
Okay, so now let's get to the Q&A, as Gerald mentioned. Dr. McAlister, would you please join us again?
Here we go.
Hello, hi. So Dr. McAlister, so great to have you back, and Gerald may be staying on with us here to help field some of these questions. So Dr. McAlister, are you ready to answer some questions?
Absolutely.
Okay, great. So the first question is, have you gotten any new referrals from doctors or other clinics because you have the device?
We did. It was a little bit slow at first because even still, you know, we were having to educate other doctors on what it was and how to use it, and then you know, fortunately where we are, you know, there's a lot of doctor offices and things like that. So I actually spent some time going around, especially with orthopedists and anybody that might have contact. But I also went around to a lot of the schools as well, started talking to the athletic trainers and telling them about the device and sharing the information so that they would, you know, refer athletes as well. So that was kind of the approach that I did. And then, yeah, that's where we started getting a lot more athletes coming in.
Okay, and how, you did touch on this in your presentation, but how fast after the treatment do you start to see an effect? Just to reiterate.
I'll be honest with you, after the first treatment, you know, my patients tend to notice an effect. You know, it may not necessarily drop the pain down to zero, but they notice an effect right away.
Yeah.
So, yeah.
We've heard other practitioners say the same thing, immediate results right after treatment.
Yeah, it's been pretty consistent. Everybody that you know we've treated with it, they've had instant pain relief, you know, after the first treatment. So
Excellent.
Yeah, great. Okay, so there may be a tiny bit of confusion here about the mechanism of action. I have someone asking, is it a sound wave or a mechanical wave?
well, it's an acoustic wave that, you know, is generated by an electromagnetic pulse. So it's, but and it does make a little bit of noise while, you know, while that pulse is generating. But the sound is generated more from the movement of that electromagnetic pulse that's going on, you know, forcing the projectile, and it's taking that projectile and repeatedly going inside the applicator, generating that pulse. So
Okay. For which indications have you had the best outcomes and why?
The best outcomes have been consistently with muscle injuries, tendinopathies, strains, obviously muscle tears that we've had to deal with. Those are the ones that we've seen the most drastic results with. Mhm.
Okay, that leads me to a question here. My understanding is that it cannot be used over a bony prominence. So how can you use it for the conditions like what you just mentioned?
So, obviously, like, with a hamstring injury, we're right there in the belly of a muscle. And when we've had issues with tendinopathies, especially with ankles and wrists and things like that, tend to treat further up away. Obviously, you want to be directly on the bone itself, where that tendinopathy is, but I come back up a little bit further onto the muscle that's a little distal to wherever that inflammation is, and that's where I go in and I do the treatment with that. So
Okay, and what is the patient feedback after the therapy that you've gotten?
thus far, I mean, all the patient feedback is that we've been able to turn conditions around, especially with that one that's probably one of the worst cases that I've had was the hamstring injury, and I mean within about another week and a half to 2 weeks after we sent him back, he was back on the field playing again. So everybody else has been pretty consistent, being able to return back to whatever it is that they were trying to do. So.
Okay, speaking of hamstring injury, there's a question here. How would you treat a proximal insertional hamstring strain technically with this modality? How would it be done technically?
So I'm trying to make sure I understand the question technically. I mean, I'm going to find where the site of injury is, and I'm, find where, because it's going to be attached there to the ischial tube. So you're going to come right off of that ischial tube. You don't want to be right on it, but you're going to come, just a little distal to that, because you're going to have that strain and that inflammation is going to be, it may be right there at the ischial tube, but then, further out into the muscle fiber. So I'm going to take it and I'm going to angle it towards the ischial tube a little bit further down the hamstring, so that we're hitting that target area, but we're not directly over that bony prominence.
And another question relating to the hamstring treatment of hamstring injuries. So you quoted a success rate of 60 to 90% for a torn hamstring. Do you happen to know the control rate for healing if you do nothing?
Well, that particular injury, I can tell you with that one, and that was based off the research. So that was a compilation of the information off the research, that 60 to 90%. So that's not my numbers. That's not my rating. That was based off of what was found in the research.
Mm-hmm.
But with that particular injury, that would have normally taken anywhere from 6 to 8 weeks to recover, if not more. So that, the turnaround time on that one, when we had him, he was actually back out playing within 6 weeks. And
Wow.
yeah, he would not have been able to return to play, even consider that until after 6 weeks. So.
Fantastic.
Yeah.
Question about treatment for the spine. Is there any application possible for the spine with this device?
I believe there would be. I would say if you align out towards in the paraspinal area and angle it back towards the spine instead of going right directly over the spine or the bony prominences, you don't want to do that. But go out over to the paraspinals and then angle back towards. I think that would be a good approach for that.
Okay. How much downtime is there after treatments, and when can the patients resume normal daily activities?
So, I mean, again, that's going to be contingent upon what the condition is and what it is that you're treating. But I mean, thus far, I mean, even the ones that were a little bit less intense as what that hamstring injury was, it hasn't stopped them from doing anything. My approach to that kind of comes into a little bit of a philosophical approach as far as what you want. I don't want my patients being inactive by any stretch of the imagination. I want them to try to stay active. And I do a lot of exercise type rehabilitation, so long as they can do it without re-injuring or inflaming the area. So I think that's a little bit of an approach. Some people take more of an approach that they want them to just rest and don't do anything, and I think that's just kind of a difference in an approach for the patient. So.
Right. So the treatment with the device itself isn't going to cause any additional downtime,
No.
but you're saying it would be dependent on the injury itself.
Exactly. Yeah.
Okay. And there is an attendee asking about some of the scientific studies, and they want to know more about the science of it. And I just want to assure you, we have your name here, the person who submitted the question, and we will definitely follow up and email you whatever you need. Anyone else, requiring or wanting additional information, just hit us up, and I'll give you some contact information at the very end of this webinar. Okay.
I was going to say at the end of my presentation, I always have all my research. I don't actually show it in the research, but I have all the research that I did and all the information that I found on it. So I'll be more than happy to share those articles and those sources for you.
Excellent. Thank you. Thank you. That'd be very helpful, I'm sure. Dr. McAlister, do you need to block the area or use anesthesia when you're doing this treatment?
No.
No. Okay. And you did, I remember you went into contraindications a bit in your presentation. Maybe just review, I remember you said pregnancy, in treating in that area would be a contraindication. If you could just review some of the contraindications, that was a question.
Yeah, absolutely. So pregnancy obviously is one. Potential for blood clots, or if they have any type of blood clotting disorder. Any open wounds or infections, you don't want to do treatment or therapy over, directly over those areas. Cancer or the presence of tumors, and a lot of it again is some of the same contraindications that you would see with any other ancillary type therapies, such as electric stim, some types of ultrasound, things like that. It's the same contraindications you're going to see with those. Now, certain nerve and vascular disorders, those are, you're going to have to weigh those. Again, there is a little bit of research on some neuropathies, but I can't say to where that is. For right now, until I see good evidence of research, I'm going to tend to stay away from that because it is listed as a contraindication. So things like peripheral neuropathy, DVTs, obviously, that's someone you don't want to mess with because you don't want to dislodge a thrombosis and then end up causing an embolism. Raynaud's disease and peripheral artery disease were the other ones that were listed.
Okay, we have a couple of questions here related to reimbursement for these treatments. One question: any CPT codes? And then the other question, more generally, are any of the treatments covered by insurance?
Thus far, we have not seen anything. And that really kind of comes down to your, who does your billing, but. I would say, you could do some sort of type of myofascial with a device. So, but a lot of your insurance is not going to cover that. And so I think that's one of that's kind of difficult as far as that actual diagnosis. I mean, any of your tendinopathy diagnoses, you've got your, muscle strains, those are all, adequate diagnosis to be able to use those with. I mean, anything that's listed. Now, you also need to factor in what the laws and rules are in your state as far as your scope of practice. So if you're a chiropractor, you've got to pay attention to the laws and what you are able to treat. So for example, in the state of Texas, I would not necessarily be able to treat a non-union fracture. That's outside of the scope of our practice. But other states, they wouldn't have that problem at all. So again, those are things that you have to factor in. As far as actual, billing codes, I don't know. Because everything that we did with us is cash-based, so we didn't file insurance with it.
Can you speak to that, Gerald?
Yeah, maybe it's important here to put a little bit on what is the cash payment that people are charging for the modality. And I know the U.S. nation average is $550 per treatment session of around 3 to 6 or 8 treatments. And I don't know what you have found in Texas, Dr. McAlister. Maybe you can speak a little bit on what it is in Texas. the average?
Yeah, when I was doing a little bit of research on that, it was the average in Texas was anywhere from 100 to 300 per session.
Per session.
Yeah.
So
And
that's in line with the nation average,
Mhm.
I would say. Yeah.
now, do you charge for the office visit in addition to the treatment charge?
Well, I mean, it's it's service-based, charges. So now, if we are filing insurance with somebody, they're still going to have to pay their copay, and if they have co-insurance or whatever associated with that, and then this service would be a separate charge on top of that. So,
Okay.
but I would say you could look at things like, cash plans if you want to do, say, hey, we do a certain number of therapies, and maybe offer something that's more of a bulk rate up front, and then possibly discount it from there if you want to do things like that. Just make sure you're not violating any laws within your state where that's concerned.
Right. And are patients ever resistant to paying cash for the shockwave therapy, and if so, does their attitude change once they see the results from the treatment?
I mean, you're always going to have those patients that, you're going to have some patients that are always going to, I can't afford that type of stuff, and you're always going to run into those. It comes down to, you being able to convey and communicate the value of what it's going to do for them. And I would say maybe even work with Zimmer to get some brochures on the device, and so that they could have that information. Provide research for them. Just some people are asking me for research. Provide them with research to show that it's effective. And I really think it comes down to how well you educate your patient on how well it's going to work. You may even offer them, say, look, let's do a couple therapies. We'll do a couple therapies and see where it goes from there, and either discount it, or I mean, you could possibly offer it for free. It just kind of depends on what you want to do. A couple therapies, and if they see that it's working, then work something out from there. So there's always ways to work with that.
Yes, Gerald, Zimmer MedizinSystems does help to educate both the practitioner about the treatments as well as their patients, correct?
Yes, absolutely. We have a marketing package that comes with the enPulse or the enPulsPro. That includes like waiting room brochures to really educate the patient what it is, what it does for them in the long run. And so this helps already having them in the right mind when they're coming to you and see you. And I agree, there are always patients that say, oh, I cannot afford that. But again, if it's only 10%, or if it's only one patient a month that says, oh, I want to try this, then you're already in the positive cash flow area. And one patient per month should never be the goal to achieve. And it almost never is, from what I've heard from practitioners. I just got off a phone call last week with a doctor in Florida who said after 2.5 months, the machine is paid. So.
Excellent. Okay, so let's get back into the nuts and bolts here of treatment for you, Dr. McAlister. More questions on these. So are you using this device with acute and chronic issues?
Yes. Yeah.
Yeah.
That one, he was pretty acute, coming through. But even with chronic, because like some of the musculoskeletal conditions that has proved less effective would be things like osteoarthritis, those types of things. But it does still provide some pain relief. So
Yeah.
I would say chronic and acute would be appropriate.
So some more questions here related to treatment. Somebody mentions here that they were under the impression that treatments were supposed to be once a week. Do you have any thoughts on that, on frequency of treatment?
I mean, all the research that I was looking at, they averaged about 3 times a week. So then you'll see some protocols. There's some variation in protocols. I did remember seeing some things that were, 1 time a week, but it seemed to be the average was about 3 times a week.
Okay.
So, yeah.
Do you use it on Achilles repair post-op?
I would say yes, you could do that because that would still be kind of on the tendinopathy, but you got to make sure that that patient has been cleared. You know, that would be my advice, is making sure that patient has been fully cleared by the surgeon, because the last thing that you want to do is do something like that and then re-rupture the Achilles because it hasn't had time to fully reattach, or those types of things. So just try to coordinate and co-manage with the orthopedist on that.
Right. Okay. I was told we can use it on wounds for angiogenesis. True, false?
Well, I mean, there is that neovascularization that goes with it. You just want to make sure it's not an open wound.
Right.
I would say you could probably stimulate around the edge. You don't directly want to be on top of the wound, but you could go around the edges of the wound. It helps stimulate those areas around it. Gerald, do you have any research or anything on that?
I have to look into if there's research on that. I think there's a research on wound care, but it always states that they were obviously not directly on the wound bed, around the wound edges, so that you'll not really do additional damage or to the open wound.
Yeah, I'll be honest with you, that would be out of my scope of practice for my state. So that for me personally, no, I wouldn't do that, but different practitioners may be able to do that, and so that would be something that I would encourage them to look at the research on and see what the protocols that were used in that research. That's what we based our protocols off of, is what was done during research studies, and to see what was effective. And that's where then we also obviously follow some of the recommendations that Zimmer provides.
I have to be honest with you, these questions keep on coming in there, but we do need to let you, we will let you go, we promise. We do need to start wrapping up the webinar at some point, so pretty soon here. So I'm going to just hand you a couple more questions. This is a really good one. Can you use Shockwave on kids?
There's actually a little bit of question on that, because I have looked at that as well. And I mean, I have not seen, I've been able to use it on teenagers, high school, but when you're dealing with high school kids, especially high school males, they're more adult than they are children at that point, as far as their body development and things like that. Thus far, I have not used it on any small children. One document that I did read showed children, it just said children contraindicated as a general rule, but it did not give an age range.
Right.
So yeah, I can't give an evidence-based answer to that. I would venture to say probably if I had small children, I would use more caution.
Yes. Okay,
in our contraindication list, it's as like not on the growth plates. Other than that, it's okay.
That makes sense. Okay, so final question. I know that you did get in, Dr. McAlister, you did get in a little bit into the success rate with one specific case study. This is more general success rate with the enPulsPro, the Shockwave therapy.
Oh, I mean, as far as everybody that we've used it on, we've seen pain decreased almost to zero. It depends on whether we're dealing with a chronic or an acute condition or not. All the acute conditions went back to zero. We've seen 100% for them. Some of the chronic conditions, we will make a dent in it, but again, you're dealing with a chronic condition, so there's always going to be a little bit of residual stuff, and you're only going to be able to reverse things to a certain degree when you're dealing with a chronic condition. But definitely the 100% have seen decreased in pain, and increased in range of motion and functionality. So.
Okay, excellent. Well, thank you both so much for sticking with us through the Q&A, and Dr. McAlister, excellent presentation. Excellent presentation earlier. I really appreciate all of the information has been very valuable, and thank you for being with us. If anybody else has questions, we'll get them straight to you.
Thank you.
Okay. I'm just going to share one last slide here before we conclude the webinar. If anyone would like more information about the enPulsPro, please visit the Zimmer MedizinSystems website at www.zimmerusa.com and navigate to the enPulsPro radial pulse therapy section of the website. Zimmer MedizinSystems has also an assortment of waiting room materials available for you to browse on the shopping site at shop.zimmerusa.com. And if you'd like to speak with Dr. McAlister or Gerald Gable directly, please send an email to info@zimmerusa.com to be connected with them. And that concludes today's webinar. Thank you very much for attending. A recorded version of this webinar will be emailed to all attendees so that you may review any of this information at your leisure. Good night.